Hey, how you doing? It's Dr. Nick Tullo live.
Hey, how you doing?
Hey, come on. What are you talking about? Hey, I forgot to mute my sound here. You know, I got this fancy setup here down in my basement in New Jersey, and we're going to do a live stream this morning. Hey, from New Jersey. How are you, everybody? I'm glad to see we have a few people watching, so I'm so happy that you are enjoying this content. For those of you who are just tuning in for the first time, I'm a cardiac electrophysiologist. I practice in New Jersey, but I have this online course, ECG Academy, and I wanted to deliver something more than just ECG, something more clinical. So when you guys are faced with a patient, yes, you might be able to read the ECG, but then what do you do with the patient? So these are mostly case presentations and stories, and let's, talk for the next half hour or so. So this is going to be fun, and I hope you guys enjoy it. Good morning, everybody. I'm glad to see you're all here. Sadip and Chris and Nicola, Ahmad, and we have people tuning in from all over the world. It's really terrific. So thanks so much. And remember, if you like this content, subscribe to my ECG Doc channel on YouTube, and then you can get notified. I do this most Saturdays, but I'm going to give you a warning. I'm on call next Saturday, so I won't be doing one then. So I have to actually pay the bills. So anyway, let's get to today's case presentation. It's actually an interesting patient. You can call me Sam for this one because I was kind of a good Samaritan. I was making rounds up on one of the floors in the nursing unit, and one of the nurses just came up to me and she said, "Oh, Dr. Tullo, what do you think this is? Do you think this is?" And she said, and I was like, yes, and this is how the whole thing started. So let's talk about the patient. He was a 70-year-old fellow. He does have a history of some hypertension and peripheral vascular disease. He's chronic venous stasis in his legs, basically. Some diastolic heart failure, but his ejection fraction is normal. And so he gets admitted with really rip-roaring cellulitis in his leg. And in fact, when he gets in, he's got low-grade fevers. His blood pressure is a little bit low. And so they admit him with sepsis and put him on antibiotics. Now, he was on metoprolol at home, I guess, for his high blood pressure. So they held it. But they put him up on the medical floor, and they were giving him antibiotics. And, he was sort of pooping along. He was there for like 2, 3, 4 days. And then they were doing vital signs, and they found that his heart rate was very fast. And in fact, the blood pressure cuff got a reading of like 180. He wasn't on the monitor at that point. They had never put him on telemetry because he had no cardiac problems. So let's take a look at his cardiograms. Let's start over here. Okay, so this is his cardiogram. Let me see, we have a few more people. Richard Bogle from London, thank you very much for coming to join us in our presentation. And Drigan from Italy, that's beautiful, thank you, grazie, molto grazie. So here's his ECG, the baseline. This is when he got admitted. So it's a little bit slow because he's on Toprol. You can see it's a little above 60 beats per minute. And he's got nice P waves. It looks like a normal sinus rhythm. If we look at the limb leads here, we can make a comment about the axis, because if you notice, like 2, 3, and AVF are all down. So he has left axis deviation, but looks like lead 2 is a little bit more isoelectric than AVR. So remember, if we're talking about axis, which is something a lot of people get confused about, lead 2 is going down into the patient's left 60 degrees above the horizontal. So that would give us a perpendicular to that would give us minus 30. And AVR would give us minus 60, but we're not quite there. So I would say it's just a left axis deviation. Kind of have a little bit of almost borderline for LVH, but not quite. And just some kind of non-specific T wave sagging in the precordial leads. We have sort of a normal R wave progression, but look at these sort of like deep S waves in the lateral precordial leads. So that kind of goes along with late transition. It could be lead positioning, it could be related to the left axis. He doesn't have quite a hemiblock, but there's nothing terribly specifically wrong with this cardiogram. The QRS looks a little bit wide, so maybe some people would read a non-specific IVCD. Osman from Hermitage, Tennessee. Y'all from Tennessee, I didn't know that. God dang. You know, I spent 3 years with the Chattanooga Heart Institute, and I learned that it's really nice to live in the South because they're just nice people. I actually enjoyed practicing in Tennessee, but you know, my wife's heart was in New Jersey, so we had to come back. You know what they say, in the South they say, if mama ain't happy, ain't nobody happy. So in Dallas, Cassie from Dallas, yeah, Dallas, Texas, that's a wonderful thing. Thank you for joining us. So anyway, so here's his ECG. Wasn't, you know, terribly, nothing terribly wrong with it. So what happens is they get this heart rate of 180 beats a minute. And what should you do when you measure a heart rate of 180 beats per minute? The guy actually wasn't complaining of anything. He had no palpitations. He was a little short of breath, but he's kind of always a little short of breath. He's sort of, you know, one of those old fellas with, you know, kind of bad lungs. And but they got the 12 lead. And this is what they showed me. So let's go back to my 12 lead here, and I'm going to show you what the 12 lead looked like. Okay. All right. So there we have the 12 lead. And she showed it to me, and she said, oh, freedom, peace, and justice from Sudan. Thank you. That's great. I wish we all felt that way. I think most of us do, in fact. So so here's the cardiogram. So any ideas from the group who's listening? Anybody have a feeling for what this might be? Sort of taking a quick glance at what the rate is, it's pretty fast. I mean, it's certainly faster than 150 beats per minute. And it was measured as 180 on the cardiogram. And Sadip says AVNRT. And so how many people look at this, Nicola? Everybody's saying AVNRT. I said some people would think it's flutter width 2 to 1. And the funny thing about flutter width 2 to 1 is you have to assume that your atrial rate is twice as fast as your ventricular rate. And when you have a ventricular rate of 180, that would mean that your atrial rate was 360. So that's awfully fast for atrial flutter. It could be, but it's more likely to be some kind of SVT. Now, regular narrow complex tachycardia. Richard, if you look at the regular ECG, the QRS complex looks almost identical during this tachycardia. If you notice one in AVL, they have a little bit of ST sagging, and during tachycardia, you have even more ST depression, but otherwise the axis is the same, everything is the same. So you kind of, it's a little fast for flutter, that's right, but it could be SVT. And, you know, you have to kind of put your nickel down and say that it's SVT. Now, the most common mechanism for SVT is AV nodal reentry. So where are the P waves? That's what you have to think about. Nicola's one step ahead of us. She wants to give adenosine. So if you look for P waves, you know, the QRS is a little bit wide here, isn't it? That non-specific IVCD is kind of getting in the way. And there's also a lot of baseline noise. But I would say that the only lead where you might see P waves is maybe V1. And the reason I say that is if you look just after the QRS complex, there looks to be a little bit of a jiggle that sort of changes from one beat to the next, just a tiny bit. And I suspect that that might be the P wave, and I suspect that this was AV nodal reentry. So now I'm just standing in the hallway. I mean, I'm just being the good Samaritan, and I was a little surprised when the nurses called the internist who was taking care of the patient and he ordered a CT angio for the patient, thinking that this was somehow an indication that maybe the patient had a PE. So let's talk about first acute treatment of SVT like this, and I think most people have the right idea. You want to give adenosine, and remember, how does adenosine work? It causes AV block. It profoundly blocks the AV node for about 5 seconds, so nothing gets through. And if the tachycardia is dependent on the AV node, then that's going to basically fix the problem. So let's, just for those newbies who want to learn more about SVT, oh, that's a terrible heart, didn't I? I did a terrible job of that. But so your AV node is, as you know, the connection between the top and bottom chambers, and you've got the His-Purkinje system down below. But in most people, there are several extensions of the AV node. There's an anterior fibers, they're known as transitional fibers, that very rapidly conduct the signal into the AV node. And then there usually are extensions of the AV node, both on the right side, and most people have them on the left as well. And these fibers conduct much more slowly. And so what can happen in the typical form of AV nodal reentry tachycardia is that the signal, under certain circumstances, now what initiates tachycardia? It's usually a premature beat that encounters unidirectional block in one pathway. So most of the time what happens is a PAC occurs and the fast pathway is refractory, so it's not able to conduct the signal down to the ventricle. But in most patients, the slow pathway may have a shorter refractory period and is able to conduct that signal slowly to the AV node, and then the signal is able to go up the fast pathway and then turn around and go back down the slow pathway. So it starts going round and round. You have a premature beat that goes round and round. Oh, darn it, I'm not showing my signal. Oh, that's terrible, because somebody ought to let me know. I forgot to press the button. So here's the heart that I was drawing. I should rewind the tape. So your fast pathway is at the top, your slow pathway is at the bottom, and you have reentry down the slow and back up the fast, and that's the typical form of so-called slow-fast AV nodal reentry tachycardia. Is everybody born with fast and slow pathways? I would say yes. Under the right circumstances, you can bring out slow pathway conduction in most everybody if you sedate them or enough, but you can't always bring it out in the EP lab. If you're interested in how to initiate it, how this AV nodal reentry tachycardia works, and how you can actually study it in the EP lab, you should check out in my advanced course on ECG Academy. I have a whole section on PSVT, and it talks about the EP testing in the lab and how you do His bundle studies and how the AV node behaves and how AV nodal reentry tachycardia gets started. It's a really cool discussion, especially if you work in an EP lab. It's really very helpful. But the AV node is obviously part of the circuit here, and that's why adenosine works, because what adenosine does is it blocks the AV node just for a few seconds, but if the AV node is part of the circuit, then that causes the tachycardia to terminate. There are a couple of different tachycardias where the AV node is part of the circuit. AV nodal reentry is one. And the usual form, the slow-fast form, is going down the slow and up the fast. And that's usually, you don't see P waves during slow-fast, except maybe at the tail end of the QRS complex. You might see a P wave, just sort of peeking out from behind the QRS. You can also have fast-slow, where it's going around the other way. That gives you a long RP tachycardia that has more of an inverted P wave in front of the QRS and a long RP and a short PR. But listen, that's a whole other discussion. We're only here we're not here all day. So anyway, I kind of suspected that this was AV nodal reentry, just like all of you did. If this was atrial flutter and you gave adenosine, you would block the AV node, but the flutter would continue. And what you would wind up seeing is flutter waves with AV block. So you'd see flutter waves at twice the rate of the tachycardia, but adenosine doesn't stop atrial flutter. All it does is blocks the AV node. So with atrial flutter and atrial tachycardia, the atrium is driving the circuit and the AV node is just a passive participant. It's known as a bystander. So if you block the AV node, you'll get lack of conduction down to the ventricles, so the QRSs will go away, but the atrium's still functioning. And then 5 or 10 seconds later, when the adenosine wears off, the tachycardia goes right back to where it was before. So that's one thing that you could have done. Unfortunately, we're on a medical floor, and they didn't have adenosine handy. The patient was pretty stable, but I did kind of, as a good Samaritan, ask the nurses to get some IV diltiazem. And so we put, first, actually, I did listen to his carotids, and he had no bruits, and he had no history of any stroke or anything. So I tried carotid massage, and it didn't work because this thing, it obviously had been going on for hours at that point. He wasn't on the monitor. We don't know when it started. But carotid sinus didn't work. I had him do a Valsalva. That didn't work. So then I finally decided, okay, let's try IV diltiazem since we didn't have ready access to adenosine. And so here's what happened. First, initially, he went from 180 beats per minute, and he gradually slowed down to about 150, and then he got to like about 140, and the nurses were like, "Ooh, it's working!" And I was like, not yet. All we've really done is slowed the circuit down. We've slowed conduction down the slow pathway, and so the tachycardia is still going on, but it hasn't broken yet. But about 5 minutes later, this is what happened. And you can see the tachycardia in the first two strips, and then right here, the tachycardia breaks, and then you're left with sinus rhythm with some PVCs. And it slows down. Here's the sinus rhythm going on. So the diltiazem eventually worked to break the tachycardia. Now, for those people out there who are into the EP world and who really pay attention to mechanisms and so forth, what exactly do you think happened to cause this tachycardia to terminate? Okay, so here you've got, it's going down the slow pathway, back up the fast, down the slow, up the fast, and of course, every time it reaches the AV node, it goes down to the ventricle and up to the atrium simultaneously. That's why the P waves are buried in the QRS complex. And then it goes down the slow, back again, and then up the fast and down to the His bundle at the same time. So what exactly happened to cause this tachycardia to block? Any ideas? Because this is the cool part. This is where you start to imagine the physiology. What's going on in the heart? Why did it break? Okay, not just, pop the corks of champagne and, mimosas around the nursing station. It's like, yes, it broke. That's great. But why did it break? It wasn't that the diltiazem caused AV block to occur. 10 milligrams of diltiazem. It doesn't really change the refractory period. It slows conduction time. It slows conduction velocity through the AV node. And usually, if you give IV diltiazem, it doesn't cause AV block, does it? I mean, you give 10 milligrams of diltiazem, you don't expect asystole to occur. So what actually changed? Okay, I'll tell you what. If we look at down here in the third strip here, you have this tachycardia that's going along at a rate of about 140 beats per minute. What's this? What is this beat right there? It doesn't look the same as the tachycardia beat. Now, the sinus node is not participating in this tachycardia. The sinus node is just sort of like hanging back because the atrial rate is 140. So the sinus node is just sort of doing nothing. So what is that? What is this beat right here? What do you think happened at this moment right there? What is that? Does it look like a regular beat? Does it look like a regular tachycardia beat? I don't think so. Did it come on time? Well, if you look at the time distance, the time interval between the T wave and the next QRS complex, that's a good way of telling if it came on time. Look at this interval here, and now look here. Okay? It's not an aberrant beat because it came early. And so I think this is a PVC. That what happened was the tachycardia slowed sufficiently so that a PVC could sneak in. Because you have this beat, and then you have this beat, which looks like maybe another weird looking PVC, and then you have this beat. So you had like this flurry of ventricular ectopy. And that's what upset the apple cart. That's what upset the tachycardia. Okay, because you have this signal that's going down the slow pathway and back up the fast, right? And it's going round and round. But now you have a PVC that manages to get up the his Purkinje system to the AV node. And that PVC, or series of PVCs, what it can do is it can retrogradely penetrate the slow pathway so that the next beat that comes around now encounters the slow pathway that's refractory. And that's what causes the tachycardia to break. So this slowing the rate down allowed the spontaneous PVCs to occur. And that's what got the tachycardia to break. Okay, sort of a crazy advanced concept. Now, if it was adenosine, we know that blocks the AV node, tachycardia terminates, end of story. But with diltiazem, it doesn't always work to break the tachycardia. The first thing I said to the nurses was, yeah, okay, you've slowed the heart rate down to 130 or 140, and that's great, but in 20 minutes, that IV cardizem is going to wear off, and it's going to go right back to where it was again. Until it finally broke, and I was like, oh, that's why it broke, because you slowed it down enough to have a few PVCs to occur. Now, look at after it breaks, you've got sinus rhythm, but you've got all these other PVCs here. You've got PVCs all over the place, and it turns out that after this all happened, this was his rhythm strip. After the event, like maybe a couple of hours later, he's got very complex arrhythmias, including a lot of PACs, some that conduct aberrantly. Here's an upside down P wave, here's an upside down, up and here and there. A lot of atrial ectopy, as well as a bunch of ventricular ectopic beats. But he wasn't on the monitor, so we had no idea that he had all this. And I suspect that maybe the metoprolol that he was taking was somehow keeping this under control. And because he got admitted with sepsis and his blood pressure was low and they held the metoprolol, now all of a sudden these sort of like underlying ectopic beats appeared, and that's what triggered tachycardia to occur. Now, keep in mind something very, very important that I want to discuss, and this was the reason why I brought this whole case up, is that PSVT is an electrical disturbance. It's due to the presence of a fast pathway and a slow pathway. It's not due to anything else. It's not due to a pulmonary embolism. It's not due to an acute MI or acute ischemia. You don't get PSVT necessarily because of electrolyte abnormalities or hypoxemia. Now, when you have these two pathways in the AV nodal system, a premature beat is what triggers the tachycardia to get started. So fine, if you're hypokalemic because you're on diuretics, well, then you're going to maybe get more premature beats and you're more likely to initiate tachycardia. But that's the only reason. You have to have a short circuit. You have to have dual AV nodal pathways or an accessory pathway or some other electrical disturbance. And then that something will trigger it to occur, but not a PE. I mean, doing a CT angio made no sense. And certainly doing any other kind of testing, even, a lot of residents would say, oh, let's send off cardiac enzymes. Why? Why would you send cardiac enzymes on someone who really was having an arrhythmia? It had nothing to do with ischemia. There's no point in checking them. It only perhaps opens Pandora's box. He had no chest pain, and as soon as his rhythm went back to normal, the ST changes went away completely. They were probably just rate related. Sure, I mean, he deserves a cardiac evaluation. He deserved to have a cardiologist. Does he deserve an ablation? How many people would recommend that he have an EP study and a catheter ablation? Well, he had no symptoms during this episode. So that raises two questions. First, is it really the first time he ever had it? I mean, could it be that he had other episodes at home and he didn't realize it? So I think it might be worth monitoring the fellow, because certainly this is an arrhythmia that can easily be cured with an ablation procedure. But if it happened because he's acutely ill and someone stopped his beta blocker, and it was sort of like under extraordinary circumstances, then maybe you don't necessarily need to recommend an ablation. But certainly you have to understand that this is a primary electrical problem. Okay, it's an anatomical aberration, or maybe even a normal variant that goes berserk, but you have to treat it that way. You have to understand the electrophysiology of it, and that's the only way you're going to be able to treat these problems appropriately, and not kind of go off on a tangent and start ordering a nuclear stress tests and putting the patient, having him run through hoops of fire in order to satisfy yourself that, okay, well, there's nothing else going on. You don't need to look for something else. It's like someone who comes in with a broken leg. I mean, the problem is the broken leg. You don't need to necessarily look for, other reasons. So I just wanted to put this all into perspective for you guys, because, you're out there treating patients and you maybe come upon these type of tachycardias. And so in a way, a lot of people don't want to miss anything, and that's kind of what drives that cost of healthcare up. I don't know about everybody, internationally, but in the U.S., the cost of healthcare is outrageous, and I think part of the problem, a significant part of the problem, is that people are afraid that they'll get sued for malpractice. So there's a lot of defensive medicine that goes on. There's a lot of people will order 1 million tests just to make sure that you didn't miss that 0.5 of 1%, and wind up being blamed for a bad outcome. But you do have to put everything in perspective and understand the nature of these arrhythmias, because otherwise you're going to order unnecessary testing. You're not going to treat the patient appropriately, and the outcomes might not be great. So in fact, what I did was I put the patient back on metoprolol, and he stayed stable for several days after that. Then another cardiologist came by and put him on PO Cartogram. And, I actually didn't agree with that. I mean, we don't really know that this is an ongoing problem. Certainly if he is having recurrent episodes of SVT and for whatever reason doesn't want to have an ablation, then you might have to use combinations of a beta blocker plus a calcium blocker to slow the AV node down or suppress the ectopy enough so that he doesn't go and have tachycardia all the time. But if you have somebody who presents with SVT like for the first time, and then you get it to break, there's no point in putting them on Cartogram, PO. There's no point, because you don't know what the natural history is. It could be that he won't have an SVT again for 10 more years, right? Sometimes people get an SVT for the first time and it never happens again. So why put the patient on a PO med when the problem is already resolved. The problem's gone. They're out of SVT. They're back in sinus rhythm. Yes, they have these dual pathways, but it took all these years for something to occur. Putting somebody on oral Cartogram kind of doesn't make sense to me, unless you're, like I said, treating a recurring problem. So let's take a look and see what kind of comments we have, because a lot of people are engaged in this conversation. And Nicola, does it usually break all diltiazem? I was surprised, and verapamil actually I think works better than diltiazem, but verapamil is hard because you just are able to give a bolus. Verapamil probably work 75% of the time, Cartogram maybe 50 or 75, but the mechanism of adenosine is much more effective in terms of like terminating tachycardia. I wouldn't recommend an ablation because I don't know that this is a recurring problem. This may have been just sort of, like I said, extenuating circumstances. Sometimes a little bit of beta blocker rebound, and in the setting of all this ectopy, he might have had this tachycardia. But I just had this sneaking suspicion that he's had this before and just never realized it, perhaps. So anyway, I think it merits monitoring the patient one way or the other to see if anything needs to be done in the future. Sadeep says, if arrhythmia starts with PACs, it would make more answer. Like flecainide is a great drug to use to suppress PACs and PVCs. So if you have a patient, maybe they're very old and they don't want to have, or they don't want to have an invasive procedure, they don't want to have an ablation, and yet they're having episodes of SVT, flecainide would actually do a good job in preventing SVT from starting. But again, when you can spend an hour or two in the lab and ablate the slow pathway and cure this problem for good, why would you start flecainide and all these other exotic antiarrhythmic drugs to treat a problem that's otherwise curable? One electrophysiologist I once met said, so what's the drug of choice for acute appendicitis? Well, really there isn't. You want to surgically remove the offending problem. So that's the thing about SVT like this. If you can eliminate it with an ablation procedure, why would you mess around with drugs? Because this is an anatomical problem and it's not going to go away overnight. It's certainly not going to disappear spontaneously. It's always going to be a potential problem until you get rid of it. Now, it may be a very infrequent problem, and I have patients who come to me who have had 3 tachycardias over the course of 10 years. And when they get it, it lasts about 20 minutes and then it breaks, and then they're fine for 5 more years. And those patients may elect to not do anything, to just live with it. But certainly an ablation is a viable alternative for that. And you're right, Nicola, don't use flecainide if you have any kind of structural heart disease. And some people don't give it if they even have coronary disease. But I would have just left the guy on a beta blocker, and I would have just monitored him. Maybe you can put a 2-week event monitor on him to see if he's having any ongoing arrhythmias. So, question about the ECG. Chris says, what causes the wobble in the RP interval when it was going at 180? Well, that's a good question. In an old fellow like this, sometimes you will get just a very slight, 10 millisecond variation in conduction time, especially in the slow pathway. And then you will get slight variations in the R to R interval, even 10 to 20 milliseconds or so. That's especially seen when slow AV nodal reentry, when the P wave is more in between the 2 QRS complexes, because the slow pathway has a lot of beat-to-beat variation. So, so let's see. When you ablate this arrhythmia, do you work on AV node or right atrium? You're in the right atrium, and so So this is your tricuspid annulus that you're looking, you know, in an LAO projection. Okay, so your AV node is going to be up here, and your coronary sinus ostium is going to be down here. So you have a wire that's in the coronary sinus, so you know where the os is. Usually the slow pathway is going to be between the annulus and the CS, someplace in that region. So you want to avoid where the AV node is, and you have a His bundle catheter that's up here. So you're always monitoring where your catheter is with respect to the His bundle, and you're usually at least a centimeter or two away from it. But that's the ideal place to burn, is adjacent to the coronary sinus. Now, if you listen to Sonny Jackman and a lot of the really like brains in this in this field, you'll understand that the way I've drawn the pathway, the route of the circuit is wrong. I'm just going to tell you now, but it's too much to understand the true nature of AV nodal reentry. I'm going to probably do that in one of my advanced lectures. If you guys email me or send me a message and you want me to go over it, I will. But you can probably find it online someplace. But it turns out that the tendon of Todaro underneath the eustachian ridge is a significant line of conduction block. So that the way I've drawn it coming up the fast pathway and then going down the slow pathway is like physiologically not possible. So it turns out the coronary sinus is involved, and you know it's much more complex than we thought. But nevertheless, you can usually reach the slow pathway at that location adjacent to the coronary sinus os, and successfully ablate it, and that's the way to go. So pregnant patients with recurrent AVNRT, most of the time we just kind of use beta blockers in patients who are pregnant. We usually try to wait for the second or the third trimester to use beta blockers in those patients. We don't want to expose them to radiation. So an ablation procedure is generally not a good idea. Although there are some people who are actually doing AFib ablations without fluoroscopy. I mean, it really takes a lot of skill to put wires up and do everything under sonographic guidance. So they'll use an intracardiac ultrasound to visualize where they are and where the catheter is. But fluoroless ablation is done in some institutions, and a lot of physicians have a lot of experience doing that, but you know, that would be the only viable possibility in someone who's pregnant like that. So anyway, I hope this was a fun experience for you. I hope that I hope that you enjoyed this time that we spent together. And next week, remember, I'm not going to be around because I'm going to be on call. So hopefully the week after, I'll put together an interesting case and present it to you on these Saturday morning clinical live streams. Thank you very much. This is Dr. Nick Tullo. Remember, if you like this content, subscribe to my YouTube channel. Let your friends know. If you want to learn more about the physiologic basis of arrhythmias and get to become an ECG expert and be able to look at cardiograms like I do, understanding what's going on, then check out ecgacademy.com, because there's a whole course in there, advanced topics and so forth. So until next time, this is Dr. Nick. Thanks very much for watching, and have a terrific week. Thanks.